Dear colleagues, ladies and gentlemen, welcome to the lecture number 5. In this lecture we are dealing with the abnormal ST and T wave changes during exercise with regard to the two different athletes population, the population of adult and senior athletes in which atherosclerotic coronary artery disease is the main responsible for ECG changes during exercise, and the population of young athletes in which the congenital coronary artery disease and myocardial bridges are the most common findings. Let's start with this. This is the usual example that we can find of abnormal ST during exercise. Let's start with the first issue, the atherosclerotic coronary artery disease. We know from scientific literature that in athletes which are 35 years of age or more, the ischemic heart disease is the most common responsible for cardiac events, sudden death and cardiac arrest. There were also other minor proportion of these athletes that have events related to cardiomyopathies, electrical diseases, valvular diseases, but overall the ischemic heart disease is the main cause of cardiac events in the population of adult and the senior athletes. And just to remind some figures, for instance, here you can see a young Paul Thompson, that was one of the first authors that actually reported that prevalence of cardiac events is 7 times higher in athletes than in sedentary population. Even larger figures are reported by Siskovich and others. In other terms, the scientific literature is in agreement suggesting that participation in cardiac sports, participation in competitive sports can actually increase the risk of cardiac events. How is the pathological examination in these adult and senior athletes having cardiac events? By courtesy of Corrado, this is a pathologic investigation in one marathon runner, middle-aged marathon runner, in which you can see both LAD and right coronary artery with an extensive fibrous deposition and lesion, and usually this non-obstructive fibrous plaque is complicated by thrombosis, and the actual thrombosis may represent the trigger for event. The schematic draw expresses how coronary artery lesion may represent the cause for events. Number one, this lesion may represent the area where increased platelet aggregation may trigger thrombus. There is the spasm of the disease segment of the coronary artery. There is an increasing flexing of the artery with a deepening of the existing fissures during exercise because of the mechanical movement of the arteries. All these events may be responsible for a plaque disruption and then the thrombotic occlusion. Indeed, one additional element is that because of this recurrent episode of ischemia, there is an increased proportion of fibrous tissue with scars. And the scars per se may represent the histologic background for ischemia-induced malignant arrhythmias. All these pathological mechanisms may explain the increased incidence of events during exercise in individuals with atherosclerotic coronary artery disease. So, we know that exercise is beneficial for a number of reasons, including a reduction of the cardiovascular risk factor burden, but at the same time we know that the exercise can be the actual moment for triggering cardiac events. How can we face this challenge? I want to report this paper that has been published by the European Association of Cardiovascular Prevention and Rehabilitation a few years ago, where a protocol for cardiovascular evaluation of the middle-aged and the senior individuals engaged in sports activities is reported. Here, the idea is that the athletes participating in either moderate or high-intensity activity should have an assessment by the risk factor, should have a self-assessment of the risk factor in order to have an idea how the risk profile is heavy or is mild. And if there is any kind of risk, then the advice is to consult a physician which is going to have a complete cardiovascular evaluation, not only to assess the cardiovascular risk profile, but also to assess the cardiac response to exercise by exercise testing. And then a safe sport participation can be allowed. However, when talking about exercise testing, which is at the moment the only available tool that we have on a larger scale mass screening, we also should be aware that the exercise testing has huge limitations. Huge limitation in terms of sensitivity. For instance, this is a meta-analysis a few years ago reported by Vic Frelicker. The sensitivity for the major cardiac events, sudden death and myocardial infarction, is quite low for exercise testing. And if we include not only sudden death and myocardial infarction, but all cardiovascular events, including also minor cardiovascular events, the sensitivity remains still very low. So we should be aware that by exercise testing we have a very limited chance to identify those individuals that are going to have cardiac events during exercise. And this is testified by this case. This is a male mid-distance runner, totally asymptomatic, however with a relevant risk profile characterized by hypercholesterolemia and glucose intolerance. The electrocardiogram of these athletes was relatively normal. We may eventually underline the presence of positive but very small, almost flat T wave in V6, in VL, and D1. So in the lateral leads, the repolarization was not so normal. And during exercise, actually, there were a kind of very mild repolarization abnormality also shown here in the precordial leads. Overall, the picture of this athlete was not so striking, was not so concerning. However, we, based on the cardiovascular risk profile, we asked for CT scan. And the CT scan actually a diffuse spot, calcified spot were seen over the LAD and circumflex and the right coronary arteries. The CT scan shows a diffuse calcium spot over LAD and circumflex coronary arteries with a mild stenosis that was judged to be 40% over LAD. Some irregularities were also present in the right coronary arteries. However, we were not pretty much concerned, we were not pretty much convinced by CT scan because of this relevant proportion of the calcium score, and on the advice and suggestion of the clinical cardiologists, we also were proceeding to the coronary angiography, where the coronary angiography showed a very much relevant stenosis over the LAD and the circumflex that were undergoing also complete revascularization. So in this case, the coronary angiography shows even more diffuse and more severe atherosclerotic coronary artery disease, with the LAD and the right coronary arteries showing diffuse irregularities without significant stenosis, but circumflex showing 80% stenosis on proximal and 70% on distal tract that were missed by CT scan. At this time, the wise question is when a CT scan should be indicated in adult athletes. This is still controversial. The guidelines are there is no general agreement on the guidelines. So what you can see here is our advice. We suggest to proceed after exercise testing with a CT scan if there is a definite positive response of exercise testing with a clearly abnormal repolarization of changes in asymptomatic athlete, totally asymptomatic athlete, or when there are equivocal or symptom or borderline ECG changes during exercise in an athlete with a high-risk profile for coronary artery disease, or when there is the need for define the presence of coronary artery disease in individuals with other pathologic conditions such as hypertension, cardiomyopathies, valvular disease, and so on. What regards the eligibility for competitive sports participation in individuals with coronary artery disease. Here, the previous guidelines are quite restrictive. And in the terms, the usual idea is that people with ischemic heart disease should avoid the competitive sport participation and should be restricted to only low or moderate physical activity. Let's go now to the population of the young athletes. In the population of the young athletes, we should have in mind that an abnormal exercise testing can be an expression of a myocardial bridge or other forms of congenital coronary artery anomalies. Myocardial bridge, which is shown here, is represented by the deep intramural tract of one coronary artery, usually the LAD. The location of myocardial bridge is usually on the left anterior descending, occasionally on the diagonal, less commonly on the other coronary arteries. And why myocardial bridge is relevant for ischemia? Because of the milking effect, which is shown here. The myocardial tract is squeezed during systolic contraction and there is a reverse flow. Those are some pathological images derived from individuals with a myocardial bridge. These very clear images of the intramyocardial course of the coronary arteries, and this is the fibrous substitution, fibrosis replacement in the areas where the several episodes of ischemia that's shown here had occurred over several times. So myocardial bridge is relevant in clinical terms not only because it can cause an acute ischemia during exercise, but also the repetition of several episodes of silent subtle ischemia may cause a replacement fibrosis, which may represent the background for ventricular arrhythmias. CT scan is a wonderful tool to identify myocardial bridge, as you can see here in these images. And here again. Then you can see here this intramyocardial course of the left anterior descending. Also other images. And CT scan now represents the first step imaging technique for diagnosis, non-invasive diagnosis of a myocardial bridge. Let me present this case. This is a snowboard player, male, 36 years old, that we saw a few years ago at the pre-Olympic evaluation. The family history was positive for ischemic heart disease, hypertension, and dyslipidemia. And also these athletes, which had a negative personal history and a negative physical examination, had also an increased cholesterol level. During this, the resting ECG, which actually show mild electrocardiographic changes in precordial leads, here, V4 to V6. During exercise, a clear downsloping of the ST segment with inverted wave is seen in the precordial leads V4 to V6, and also in inferior standard leads D3 and VF. At greater magnification, the ST segment depression is clearly evident. And the CT scan showed actually an intramyocardial course in this intermediate segment of the LAID, and one in the proximal and one more in the distal region. We then proceed with the myocardial scintigraphy, which showed a transient reduction in the captation of the tracer during effort, and eventually coronary angiography actually showed the intramyocardial segment and the milking effect during the systole. Another case, this is a younger, 16 years old male soccer player that we saw at the pre-participation evaluation. The family history was negative, the personal history was totally negative, the physical examination was totally unremarkable. The only abnormality came again from the ECG, and specifically from the exercise ECG. This is the images of the exercise ECG, where a downsloping at the ST segment is evident in the precordial leads V5 and V6. The CT scan showed more than 20 millimeter intramural course of the LAID, and then how can we combine this case, how we can define the eligibility for sports competition? Because at this time there are no criteria defined in the current guidelines, and there is uncertainty, mostly because of the lack of clinical information over the long-term follow-up of these individuals. We suggest that if there is evidence for inducible ischemia on provocative testing, then we suggest to refrain from competitive sports, to withdraw from competitive sports. We believe that ischemia is more likely to be present when the myocardial bridge is more deep and more length. And if there is the evidence of exercise-induced ventricular tachyarrhythmias, either complex or very frequent, this could be an equivalent of risk, and these individuals should be refrained from competitive sports participation. However, we also should acknowledge that the myocardial bridge is more likely to be more frequent than believed, and that there is very likely the larger proportion of these individuals with the myocardial bridge having no symptoms, no events over follow-up, which are totally unknown at the present time. Finally, what about the congenital coronary artery anomalies, congenital in origin? The congenital coronary artery anomalies represent a very serious case of sudden cardiac death and cardiac arrest in young athletes. In both the casuistics of Italian and US athlete population, the congenital coronary artery anomalies represent a substantial subset in a range of 12 to 17% of all cases of sudden cardiac death. And which are the reason of this so risky condition? Here you can see this is the right coronary artery, which start in the abnormal place from the left sinus. The ostium of the right coronary artery is oval, and the course is between the aorta and the pulmonary trunk. During exercise, this ostium is still more narrowed, and both the aorta and the pulmonary artery, because of the increased cardiac output, they grow in size and stiffness, and they squeeze the abnormal course of the coronary artery. With regard to the opposite, here we have the right sinus and the left coronary artery starting from the wrong sinus with the oval-shaped ostium and the proximal course between the aorta and the pulmonary trunk. And the same occur, as described above for the right, also occur for the left coronary arteries during exercise. Those are the reasons because the wrong sinus origin of the coronary artery are considered so risky. Let me just present one case derived from personal experience. This is a judo player, 30 years old, with a negative family history, negative personal history, no symptoms at all, which had a normal physical examination, which was actively engaged in judo player. And the electrocardiogram, the basal electrocardiogram, was totally normal. During exercise, however, we found such an abnormal pattern, which was represented by mild ST segment depression, which was borderline. At the echo, however, then you can see here, this is the anterior right sinus of Valsalva, where there is the right coronary artery origin here and going this way, and then there is the left coronary artery originating from the same sinus, wrong sinus, and going into into this direction, your right side, between the aorta and the pulmonary tract. And here you can see this is the proximal origin of the left main. Then you can see also the flux within the left main coronary artery. The CT scan clearly depicts this abnormality. This is the anterior sinus of Valsalva. This is the right coronary artery going into the proximal course, which has a normal size. Please consider also the ostium of the right coronary artery, which is totally normal. By comparison, the ostium of the left main coronary artery is oval, is more oblique, and the course, the proximal course, is more narrowed between the aorta and the pulmonary trunk. This is also another images of the same case. In this case, we also perform a myocardial scintigraphy, which actually showed a transient reduction of perfusion in the anterior and apical free wall. And then again, if we want to suggest when is CT scan useful in young athletes, I would like to say that CT scan can be suggested when there is a distinctly abnormal response to exercise with a clearly abnormal ST segment depression, more than 2 millimeters in depth, consistently induced by exercise, even in the absence of symptoms or previous events. Or if there are symptoms, usually syncope, in association with ST segment depression, even not significant during exercise, and or the presence of very frequent or complex ventricular arrhythmias. We should acknowledge, however, that these are not strict indication. These are relatively, let's say, restrictive indication in case we want to be very safe, but there is no general agreement. This is an issue where more clinical information and more studies, including also follow-up in the data, are required to make a final statement. Finally, what about eligibility in athletes with congenital coronary artery anomalies of the wrong sinus origin? These athletes, because of this risk associated with the presence of this abnormality, these athletes should be excluded from participation in competitive sports. And eventually, discussion about a resumption of competitive sports can be discussed after surgical treatment, which, however, raise a number of medical and legal issues and also question about the follow-up period. In summary, in this lecture we understand that atherosclerotic coronary artery disease is the most common cause for cardiovascular events in adult and senior athletes, that identification of asymptomatic athletes at risk is recommended by risk assessment and electrocardiographic screening by exercise ECG, although we should be aware that the sensitivity of exercise testing is relatively low. At this regard, the CT scan can increase the diagnostic power of the screening for coronary artery disease. In young athletes, the myocardial bridge is a relatively frequent abnormality and is now being identified in a large number of asymptomatic athletes. And the presence of myocardial bridge can be suspected by the abnormal exercise response to exercise. More relevant in terms of clinical outcome are the congenital coronary artery anomalies that may occasionally be found by abnormal exercise ECG, and the imaging testing can confirm a diagnosis. And we should be aware that these athletes with congenital coronary artery anomalies are at a very high risk for sudden cardiac death, and the current recommendation are for disqualification from competitive sport. This is the end of the lecture number 5.